some athletes maybe don't even want to tell anyone that they're injured. Mental health is such an important part of this.
It's great to work with the athletic trainers sooner rather than later. As an orthopedic surgeon, addressing that concern before they even think about it is very helpful.
It's incredible the work that you do, not just you, but the whole team, having to make these quick decisions when you're seeing things happen.
Athletes want to understand their diagnoses, understand their options.
So we have to be prepared to have these kinds of conversations.
I do feel like especially athletes very much know their body and they know what they want to put them through. It's 50% what myself and my OR team do and 50% what the patient and physical therapy does.
Today's guest is someone who doesn't just treat athletes, she helps shape the future of sports medicine at the highest level. Welcome, Dr. Karen Sutton, a board-certified orthopedic sports medicine surgeon at Hospital for Special Surgery and associate professor at Weill Cornell. A former Duke lacrosse captain turned nationally recognized surgeon, she specializes in arthroscopic surgery of the knee, hip, and shoulder, giving athletes a way back to peak performance. Beyond the clinic, she serves as Chief Medical Officer for World Lacrosse, Head Team Physician for U.S. Women's Lacrosse, and Team Physician for U.S. Ski and Snowboard, bringing her expertise from the sidelines to the global stage. With more than 30 publications, 80 presentations, and frequent media appearances from NBC to ESPN, she's become a trusted voice on injury prevention, women's sports, and what it really takes to keep athletes in the game. Karen, I am so excited to chat with you today, and
Thank you.
I can't believe it's been I think 3 or 4 years since I've seen you.
I would say about that, but I feel like we see each other virtually.
Totally,
so
and which is, I love that about social media because I feel still connected to you even though we haven't met in person in a while. And the last time you were on the pinnacle stage giving our welcome address, and it was such a powerful talk. You really had people with goosebumps on them in the audience. It was so great. So thank you for that.
You're welcome. It was my pleasure.
I would love to start talking about you being a team physician for the USC ski team, the lacrosse team. I'd love to hear about the other sports teams, professional sports teams that you've worked with, and what that experience has been like for you.
Sure. It's been certainly great at the current moment. I just got back from Chile with the U.S. ski team and worked with their speed athletes who send themselves down the mountain at 80 miles per hour, 90 miles per hour. So it's a really intense sport, and it's a huge team sport for the medical team as well. I would say not just for the athletes, but for the medical team. And then USA Lacrosse is going to the Olympics in 2028, so that's an exciting time as well. And it certainly has been truly an honor to work with these teams, and backed up by basically residency and fellowship where I worked with professional teams as well as college teams.
So tell me about a medical team that travels with a professional high-level athlete team. It's not just an orthopedic surgeon. Who else is part of that team?
Right. I would say during fellowship up in Boston, where we worked with the Patriots, we worked with the Red Sox, New England Revolution, the soccer team. It was a huge group of us who really had to care for the athletes. It's not always the people directly on the field, but it's also the backup that you have too. For example, in football, it goes all the way from having spotters in the stand where you have other medical personnel looking at the field, seeing if they see a concussion that the doctor may not see. Obviously, it's a massive amount of players on the field and all the sidelines. So those people are actually looking for signs of concussion from afar, to the team meeting prior. Every time you are starting a sporting event, it's great to have a pre-game trial where you're talking to everyone, talking about the emergency action plan, knowing who the personnel are.
It's incredible the work that you do, not just you, but the whole team, and having to make these quick decisions when you're seeing things happen. Let's switch to female athletes. Tell me your experiences with working with female athletes. I know it's a passion of yours.
Yes.
You really do a lot of ACL reconstructions and just also a lot of that preventative care for female athletes.
I find the first thing for female athletes, we actually published a study on female orthopedic surgeons and understanding the mind of the female orthopedic surgeon, are very similar to athletes, where female athletes in particular, they like to feel prepared. They like to understand the why behind things,
Yes.
not only on the field, but when you're talking medically as well. I think the time now is where athletes want to understand their diagnoses, understand their options, and I don't think we're dictators in the field of medicine anymore. I think we're really helping them be educated and formulating a plan with the team and the athlete rather than just ourselves.
And what kind of education is happening before the injury for female athletes? We know that they're at increased risk for ACL injuries. What kind of training and preventative programs are you helping develop or you've developed, and what are you seeing out there that's helping them before they actually injure themselves?
Before they injure themselves, I think it's great to work with the athletic trainers as well as the strength and conditioning and performance coaches. Through that team, you can get a lot of pre-assessment where what's the strength of their glutes, how high is their vertical jump, how are they moving side to side, and you can follow that in season where if an athlete has an ankle sprain, you know what to rehab them during that time. So we're getting a lot of preliminary data to understand how they're moving, their strength patterns, and then what they can work on during the season, including what is their weakness. So do we change their position or do we change their skis, their ski boots? For the lacrosse athletes, we're doing study at HSS now where we're looking at the surface and shoe interface. If athletes are playing on grass versus playing on artificial turf versus playing on more of a grassy type turf surface, the shoe should really match that surface so that you're not getting too much grip or too much sliding in between. Both of those factors can really result in potentially injuries to the ankle, the knee, the hip, and we're trying to minimize that risk factor of the shoe surface interface.
And are you seeing with these athletic trainers that they are giving out different education to females versus male athletes? Are you seeing that happen more and more and at an earlier age?
Before the season starts, a lot of that preseason programming is educating the athlete in terms of injury prevention in the form of strength and conditioning. It's also in the form of educating them to know who that team is. So if you do have a problem, gone are the days they're kind of hiding in the corner and, oh my gosh, I have an injury, I don't want to tell anyone. But it's important even before you're noticing that the injury may need aggressive treatment, but you're noticing a tweak or a change, it's great to work with the athletic trainers sooner rather than later.
I think that's something great that you pointed out is that some athletes maybe don't even want to tell anyone that they're injured. How are you working with, I know you see a ton of patients of this age group, how do you work with parents and coaches and athletes to make sure that there is good communication and transparency in talking about these things?
I would say the big jump is between high school athletes and college athletes.
Okay.
In high school, I feel like the athletes have a lot of resources with talking to their parents, talking to their friends. There's a lot of outside influences that can really support them from the mental health standpoint. As athletes are getting to college, I think they're nervous sometimes talking to their new teammates, their new coaches, understanding the athletic trainers, and they might be scared to approach them in the beginning. What I try to talk to my athletes, for example, if an athlete has gone through a 9-month recovery from ACL reconstruction, that if I'm passing them off to college, they're ready to embrace the team, the nutritionist, the sports psychologist, the athletic trainers, even the coaches. I try to change their mindset where they want to help you. They're a part of their team rather than, oh my gosh, are you going to tell the coach that I can't play? Are you going to tell the coach that I have to sit out? That's their biggest concern. As an orthopedic surgeon, addressing that concern before they even think about it is very helpful, where you say, look, when you get to college, really try to see who's out there and who's on your team. Show up at that athletic training room, show up at the weight room, show up at those nutrition meetings, and understand all these people are really there to support you.
That is such great advice for parents as their kids are leaving for college. Oftentimes you're kind of that, you were the big fish in high school, and now you're the little fish in the big pond at college. And so I can see that there's a lot of fear for athletes in reaching out and building that support system in their new environment. So let's shift to a passion of yours, which is treating ACL tears and injuries. Mm-hmm. We're talking about this. The prevention is really important, but what is the algorithm you use when a patient comes to you, young female athlete with an ACL tear, and what questions are you noticing that they're asking more and more of nowadays?
What I notice with my patients when they come in with an ACL rupture, ACL tear, is they want to know all of their options. Most patients now, especially our very well educated younger female athletes, have something in mind. Sometimes they even have the graft choice in mind that they want me to use. What I do is I talk to the family, first understanding, I'm so sorry that this happened to them. I think really understanding that they know that it's going to be a 9-month recovery. They know what's out there and that it's a big mountain to climb ahead. First, recognizing that. Then I think the key is to really customize the treatment for the patient. There's a lot of studies now where, as much as surgery is an art form, I think we have a lot more objective data now in terms of matching the graft, matching the surgery, matching even the physical therapy afterwards to the patient. And being the patient, it talks about sex differences, age differences, sports differences, hyperlaxity in these patients, trying to understand a lot of the risk factors they may have for a potential failure of an ACL reconstruction and mitigating those risks.
And I'm sure that patients are coming and asking you about regenerative treatment for the ACL and their tears. How are you navigating that conversation? Because as we know, once the ACL is torn, fully torn, the option in terms of having it reconstructed or fixed is usually surgery. So how are you navigating those conversations?
I have an algorithm in my head when I'm talking to the patients about their ACL treatment. So when the patient comes in, let's say Jane comes in with her mom, her dad, her coach, her trainer, whoever is in there, the first question I ask is, do you need an ACL? And sometimes that actually might be no, where you have a runner who might be 45, 60, older than that, and our knees stiffen as we get older. So there is a chance that one patient does not need an ACL. That's the first question. So then if they do need surgery, so somebody who's doing pivoting, cutting sports and not just a straightforward athlete, then we talk about what that surgery entails. And that surgery, the first algorithm question after that is, could we do a repair, taking their own tissue and seeing if we can create that ACL and a functional knee with the tissue that they have, or do we need to do a reconstruction? Reconstruction is using a graft or taking tissue from somewhere else to create a new ACL or anterior cruciate ligament.
Is there a place for repair?
Yes, there is a place for repair. I think a lot of the techniques that we have now have improved since decades ago. ACL repairs were tried decades ago and they failed on a regular basis. So we got completely away from that and moved to only reconstruction. Now we have supporting structures. So if we do an ACL repair, which is usually when we take that tissue and it's mostly pulled off of the femur or the proximal aspect of the ACL, what we use is that tissue because there's usually a lot more tissue in a proximal tear versus just the mid-substance is completely blown to bits. We can use their own tissue, and then we have augmentation where we can create a scaffolding or kind of like an internal cast for that ACL, an internal protective layer that is not going to continue to stretch out and will end up being a very strong ACL.
Well, that's great information to have because I'm sure that things have changed a lot, since my training, maybe even your training, where people were just reconstructing ACLs and not even having that discussion about repair. But I think you touched on a really great topic is that patients are coming in with more information.
Correct.
So we have to be prepared to have these kinds of conversations, even if it's not possible for their particular scenario. Okay, so then you're talking about, say someone is getting a reconstruction. How are you talking to them about graft choice and how are you making that kind of decision? What's your algorithm for that?
When we're talking to patients about ACL reconstruction, it's important to have ourselves armed with the data. The Moon Group has been a great source for orthopedic data in the ACL realm. It's a group of orthopedic surgeons. They put together a lot of metadata to understand different patients and their outcomes with different grafts. There actually is a way to even put in data about the patient, and it'll spit out what their risk of failure is with different types of grafts and augmentations. When we talk to the patient about it, I really like to understand what is their level of play. Are they looking to play in college? Or sometimes it's actually a senior in high school who played soccer their whole life, and they're like, look, I want to go to college. I want to do yoga. I want to lift. For my well-being, I want to do these athletic activities, but I no longer want to throw myself around on the soccer pitch and dive for every ball. I'm changing my mentality. That can actually change our graft choice. When we talk about graft choice, we start with talking about the gold standard, which is a bone patella tendon bone taken from your own knee and that same side. Then we talk about quad tendon as taking that from an athlete and reconstructing it through the quad tendon. hamstring tendon, and also tissue from a cadaver or a dead person. And then sometimes even we have to go to the other knee if it's a very high level athlete, and we always want to take graft from the athlete themselves rather than cadaver or tissue from a dead person. And then finally, we're looking at lateral extraarticular tenodeses or augmentation procedures that if the patient has hyperlaxity or other risk factors that we're worried they're going to have a higher failure rate, potentially we might add that.
Those are a lot of options, and I'm sure it's a lot for the patient to think about and for you to go through that. Are people using AI and coming to your office with kind of already a plan laid out, and how are you managing that?
Yeah, it's interesting. I think no matter what, I want to give the patient and their family credit for doing research beforehand.
Yeah.
I'm a huge fan of when somebody opens up their phone and, I'm so sorry, I have 20 questions. Can you go through this? I love when patients or family members are organized, and I applaud them for coming in very prepared. You never want to dismiss somebody and their own ideas. I do feel like especially athletes very much know their body and they know what they want to put them through. They've probably researched some of the recovery from the different types of ACL repair or reconstruction, and that helps. I think even when I played sports in college, I played at Duke, and I always had a gut feeling before a game. I felt like I wasn't an aggressive warmer-upper. I like to do some hamstring stretches with my trainer, and then I would join a little bit later in the warm-up. I just felt like I wore myself out as a midfielder doing too much warm-up, and I like to put that out on the field. So I think as a practitioner, orthopedic surgeon, it's important to really respect and applaud the patient and their family for doing a lot of preparation beforehand. With AI, I think a lot of patients now are throwing their data from the MRI into AI and seeing,
I've seen that a lot.
What should I do? And the problem is the data doesn't always end up customized to the patient. The data is customized for all of the world and ACL reconstructions, which are different in Europe with the resources they have, different in South America with the resources they have, different in North America, even US versus Canada. Some places aren't allowed to use cadaver tissue. A lot of countries in Europe, they don't have access to that cadaver tissue. And as I speak at some of the more international conferences, I learn more that the world isn't our oyster for every single place where we're doing ACL reconstruction.
Yeah, I actually didn't even think of that, you know, in some places, some things are just not available to them. Those resources aren't there. And practice is different in different areas. I remember I did a very short stint in residency in Strasbourg and was doing shoulder there. And as you know, I trained at Columbia, which is the mecca of shoulders, and they were cutting every biceps tendon there. If they were doing a shoulder scope, your biceps tendon you were getting a biceps tenotomy. And I was horrified watching that. Like, oh, wow, like nobody would do that at Columbia, you know? So it is interesting to see how things are done in different places and how they differ from here. And I suspect AI is going to have to, you know, beef it up for that and what area you're in and what options are there for you at that time. So tell us about what people are asking when it comes to regenerative medicine. I'm sure that people are saying, hey, can you put some PRP or some stem cells in there? And what are you telling them about the data with that as well?
Regenerative medicine, especially if we're talking about platelet-rich plasma or stem cells, it's for areas that we're worried about the healing. We have a lot of data now on ACL reconstructions where if you have a meniscus tear, where we're talking about regenerative medicine more often than just ACL reconstructions, if you have a meniscus tear, there's not a lot of blood supply with that meniscus tear. Yes. I talk with patients more potentially about what we would do for the meniscus, especially if there's no ACL tear and we're doing surgery on the meniscus on kind of just tissue that you don't see a lot of blood when you're in there arthroscopically. I potentially will talk to them about adding platelet-rich plasma. Also for ACL reconstruction, I think at the time of surgery, there's so much bone marrow and stem cells and protein that's coming from when we're drilling and when we're accessing the tunnel for the ACL reconstruction that there are so many growth factors there. I think adding platelet-rich plasma at that time is really not necessary. As athletes go along in their recovery, sometimes it's the harvest site or where we're taking the graft that we find we may need to augment with platelet-rich plasma or stem cell because potentially maybe they're still having some patella tendonitis from where we took that graft. Maybe their quad is a little bit weaker and there's a small deficit where we may want to add platelet-rich plasma or stem cells. I find it a great option for some of those deficits from where we took the graft.
Oh, I love that you're thinking that way because oftentimes people are concentrating more on the graft site than the actual place that they had surgery. They're like, oh, that feels great, but my graft site kind of hurts a lot. And what do I do about that? And that's something, I mean, we counsel them on that, but I feel like it's still a little unexpected. So let's get into recovery. What are you seeing after your ACL has been reconstructed? How early are you starting them on physical therapy? What is your sort of process for that?
One of the things I'll talk to patients about, and I would say ACL tears are my longest visit for patients, is it's 50% what myself and my OR team do and 50% what the patient and physical therapy does. So I think it's really important to have the whole team involved. And I like for my patients to find a physical therapy location as well as a specific physical therapist beforehand, before I do the surgery, so that they're ready to go somewhere between 3 and 5 days after the surgery.
That's great. And then when are you telling them that they can get back to their sport? I mean, traditionally, we used to say, oh, it's going to be like, we always tell people it's going to be a year, but are you getting them any earlier than that 9 months that you mentioned before?
That question is asked a lot. I have a lot of very intense athletes who are like, what can I do to be the 7th month, recovery? What can I do to be one of the NFL players like Adrian Peterson, who's back in 5 months? And I say, look, there's a lot riding on the line, but you're not an NFL player. So I think really finding a safe approach, and a revision ACL surgery, if you tear your graft, is never as successful as the first surgery. So I would encourage you, the patient, really trying to invest in that time with physical therapy to have this one and done. You do not want a revision. When I talk to an athlete about their recovery, we go through the post-operative phase, which is 6 to 12 weeks. But then when we talk about that full recovery, there's a gray area somewhere between 6 months and 9 months, depending on their level of play, what they want to get back to. And some athletes, if they're going to yoga, if they're a runner, they may get back to 80%, 90% capacity at 6 months. If they're going to play Division I lacrosse at a very high level and they're a midfielder or attacker or defender, basically any position, and they're cutting, pivoting, that's going to be closer to 9 months. Again, I think it's really a customized plan. And what I have noticed is patients love when you're giving them little goals along the way. So, hey, look, right around 6 to 8 weeks, you can get on an exercise bike. I can get on my Peloton. I can start those apps. Yes, you're not going to be standing up and down and powering through it, but yes, you can get on your stationary bike and start moving forward. Wait, at 4 months or so, I can start running. Maybe we have you work with your physical therapist and see if that's appropriate based on objective data on your muscles and your landing and how you're moving side to side. I love partnering with the objective data of the physical therapist, so it's not just me being the bad guy, but look,
Yes.
This is what your body's giving you. I can't change what it's giving you. It's telling me that, no, you're not ready for pickleball, or you're not ready to start a NBA basketball game.
I think that's great that you touched upon the small goals, because mental health is such an important part of this. I mean, athletes are very focus-driven people, and all of a sudden this has been taken from them for sometimes a short period of time, sometimes a longer time period. So how are you navigating those conversations with athletes, parents, coaches? How are you mentioned being the bad guy. I'm sure you are with some of these people, but how are you navigating those conversations?
For the mental health component, I think it's great if you can have somebody part of your team. At Hospital for Special Surgery and our Women's Sports Medicine Center, we do have sports psychologists involved in our athletes' care, the same as we have a nutritionist. What I try to do for these athletes is really normalize the fact that sports psychologists are used by so many professional teams now that it's part of the athletic team. The first feeling a lot of athletes and parents get are, ooh, psychology. No, I'm fine. There's nothing wrong with me.
Because again, at high level, right? They
Right.
think that they don't need something like that.
Right. But I think it's a great addition.
Yes.
And sometimes objectively, you try to talk to your teammates, you talk to your coach, but there could be an ulterior motive. And whether that's consciously or subconsciously, if you're talking to a sports psychologist, they can really take a step back and get that 30,000 feet view and look at yourself as an athlete from, am I prepared? Am I confident out there? One of the biggest risk factors for getting athletes back to the field is actually that lack of confidence and lack of feeling mentally ready to step foot on that field, where you had this massively traumatic experience and all of a sudden the 9 months are playing in your head and like, I do not want to go through that again. When is that going to happen again? Is that going to happen again? And so I think having some ways to mentally focus, to visualize, to preemptively see yourself back on the field is very helpful.
I think that's a great point you brought up. And I think this, from what I'm seeing, this younger generation is a little bit better at doing that. I mean, I think we saw it on the national stage, international stage with Simone Biles. And she, was in her sport and realized something was wrong, took herself away from it and really built back that confidence to come back. So I think that this younger generation is doing a better job of that. And I think that's going to be very helpful in any athletic field. So you yourself are an athlete. I know. I follow you. I see all your workouts. It makes me feel bad about myself, but it's very inspiring and motivating. What things have you learned over the years in your own training, especially as a woman and someone who's, in those mid years and maybe your body is a little different than when you were playing, lacrosse at Duke? What are you learning in your own training and how have you approached training at this high level that you're doing?
I've learned in my own training and athletic experience where trying to find a community or a support network is really key for me in particular, and specifically for women. We like to have more of a community around our athletic experiences. That tends to bring me a lot more joy, a lot more motivation. I was just thinking too, I just did a half Ironman this past weekend. And
how many of those have you done for our listeners?
Probably 17 half Ironmans and 3 fulls, which are called 140.6 Ironmans. When I was doing this half Ironman this past weekend, I was trying to figure out, why don't I have this motivation? What am I doing? Who am I running for? And I even visualized at the end having my father who passed away and my grandfather who passed away holding my hands. I was doing the last 6 miles of the run because I just had to find something within me to feel like I wanted to conquer this and get my medal at the end. But then I compared that to Lake Placid, which was a full Ironman, 140.6, where I had my children there holding up signs. I had some friends who actually surprised me and drove up from Connecticut to Lake Placid and decorated outside of my hotel room with all this confetti and go Karen. They also met me at 4:30 in the morning and surprised me and helped me take all my bag to the appropriate area. And that is so inspiring to see. These are the people who virtually are holding your hand through the race. I think finding a community, finding a passion that you have for the athletics is really, truly key to both succeeding and to adding that longevity. Some of my patients will come in and say, I'm a runner. It's all I'm doing. If you can't get me back to running, then that's it. I don't know what I'm going to do with the rest of my life. And I like to open people's minds to understanding running is a tough one for us to do the rest of our lives.
Sure, yeah.
And I'm happy to support people doing that. I have a patient who's a senior Olympian who is still setting world records at 80 years old. However, I think we have to be true to our body, and everybody's different. And playing at Duke lacrosse, I felt like my athletic trainers could get me through anything, multiple ankle sprains, hamstring injuries. They were able to work with my body a lot easier. Now, being a little bit older than that, I realize that I am responsible for my own body. So if I'm feeling where I have nausea and having trouble taking nutrition at the 13th hour of an Ironman, what is going on? And I seek the help of a gastroenterologist, my coach, and those things are difficult to just pop back up from.
Yeah, it takes a lot more time and resources and education about those things. Okay, so we talked about the young female athlete. Let's talk about older women and osteoporosis. What kind of education are you doing for women about bone health as they're getting older? I mean, we know that it starts early. You have to supplement with the calcium and vitamin D early, but what's that education look like for you?
Whenever I see a patient come in, I try to think systemically, and that means think about the whole body, the whole picture of that patient. So an example is I had an athlete come in the other day who for 2 years has been getting into running, gotten up to a half marathon distance, and now just running through having some IT band issues, having some GI challenges during the run as well. And as much as I'm a surgeon, I do have a passion for these athletes really trying to compete at different levels. So we did take a step back and talk about adding vitamin D to her repertoire of potential supplements. She had irritable bowel, so really trying to understand where she's getting this calcium from, protein from. And I think it's important that, again, just like the younger athletes may be able to bounce back from a lot of these issues where they have an injury and they're not getting enough sleep or they're not getting the right nutrition, those things compound over time. Yeah. When I'm talking about my athletes in the fourth decade of life, fifth, sixth decade of life, then I think we really need to understand what's the environment. So sometimes you have athletes training in areas that have a lot of heat and humidity, and all of a sudden you have to understand, what's my sweat test? What am I sweating in terms of sodium? How much am I sweating? And you have to be able to replenish those. Or in New England, for example, when I was working at Yale as a team physician, we knew that a lot of athletes were vitamin D deficient in New England, and really trying to work on supplementing those athletes. And then some athletes as well, they may not be getting nutrition from protein. They may be vegetarian or gluten-free. We see a lot of athletes being restrictive in their diet, which I have to appreciate. However, we do need to understand how they're going to replenish those deficits.
Thank you for that. So as we're closing this out, it would be remiss of me not to talk about how you are in a male-dominated field like myself, but especially working on teams. There are probably not a lot of female physicians out working with teams. Tell me how that experience has been. I remember you told a great story at Pinnacle of being, I think it was a football team that you were taking care of. So tell us about that experience. Our listeners, they vary from, other healthcare professionals to patients out there listening to you talk about ACLs, but I would love to hear that from you.
When I talk to high school girls or college women as they start to get into their career, whatever it is, I think one of the sayings that I like is look a challenge straight in the eye and give it a wink. And I suffered some ups and downs in my career. So when I worked with one football team, they had never had a woman physician before. They had never had a woman as an athletic trainer. And the athletes were fantastic. They welcomed me with open arms. They saw how educated I was and how professional I was. And again, playing Division I lacrosse at Duke, I worked with a lot of these athletes all the time. They were my friends. They were my classmates. And so I was very comfortable working with them. It turns out I wasn't able to step foot on the field because the organization felt like I was a distraction to the players. And that was one of the moments that was extremely frustrating to me, to the point where certainly brought me to tears many days. Fortunately, again, I found that community to support me. I think it's easy, again, to crawl underground and feel sorry for yourself and decide that maybe this isn't the career path for me. But I'm surrounded by women like you, even a lot of my male counterparts, and who are extremely amazing mentors, really were able to pick me up. And one of the doctors that was working with me at the time, he said, why don't you end up as being the team physician for the New England Revolution during that time? And there was never a fellow that worked with the New England Revolution. It was always an attending surgeon. And it turns out I walked on that field, and one of the guys who played soccer at Duke when I played lacrosse there was on the New England Revolution. He's like, hey, Karen, what are you doing here? And all of a sudden the coaches embraced me, the players embraced me. And the same thing happened with one of the baseball teams I was working at too, which was a Major League Baseball team. And I went down to spring training, and they heard a little bit of the background about what happened to me. They rolled out the red carpet, and Big Papi was the most amazing player. He welcomed me. He would actually get my lunch for me every day, even though I asked him not to. But I think you can really turn things around. And again, look a challenge straight in the eye and give it a wink. Understand that maybe this is a great obstacle, and maybe it's going to bring in other opportunities that I may not have gotten if I just had a straightforward path.
I love that. You just took this struggle that you had, and you were able to find a new opportunity with the support system around you, and you just paved your own path. That's really amazing, and I think so powerful for women to hear. And the only way that we're actually going to be able to move forward in some of these spaces that aren't necessarily meant for us is if we take those opportunities and don't back off. So thank you so much for being here today. Can you tell our listeners where they can find you?
Sure. They can find me on Instagram at Karen Sutton MD, as well as X on Karen Sutton MD. and I'm an orthopedic surgeon in sports medicine at Hospital for Special Surgery.
Thank you so much, Karen.
Thank you for having me.
Thank you for tuning in to The Resilience Factor. If you're ready to build a stronger, longer-lasting body, make sure to subscribe and share this episode with someone who's ready to thrive. You can follow me at Dr. Pamela Mehta for more expert tips on strength, recovery, and orthopedic health. Until next time, stay strong, stay smart, and stay resilient.